I would like you to speak on electrolytes. First, I thought like it's a topic which is not very routinely discussed. And what I have observed over my last 18-20 years of clinical experience, that it is mainly restricted to patients who are hospitalized in ICU settings. The clinicians, the ICU and the intensivists, they are more worried for the electrolytes. And we have got, when we get the patients who are referred to us from the hospitals or from any other settings, we find that they are admitted with number of dyselectrolytemias. It may be sodium, it may be potassium, it may be magnesium. And there is one electrolyte which is missed most of the times, and that is the phosphate. So what I'm going to do today is I'm going to just, now as far as when I went into the literature and I start searching for the electrolytes, I found that 30 minutes is not good enough to go into the details of each and every electrolyte. So what I do is that I'll stick to some of the electrolytes which are most commonly encountered in clinical practice. And I will just try to brief the audience like how to go about the management of those disorders. Just an overview, like I'll be talking about the facts and the physiological aspects of electrolytes, their distribution, functions, and what can be the symptomatology of the dyselectrolytemias. I'll also try to discuss some common dyselectrolytemias in hospitalized patients with an approach to their management. Especially, I will stick to sodium, phosphate, and potassium. Now, some fast facts on electrolytes. We all know that electrolytes are vital for the normal functioning of the human body. In fact, when we start our MBBS education, right from biochemistry, physiology, we are just started and we are taught about electrolytes and electrolytes. And what happens over a period of years with experience and dealing with sick patients and all super specialization, we start forgetting the basics. And sometimes we ignore some of the common things which can manifest and can change the outcome of the patient. Some of the common electrolytes which we encounter in our daily practice, the disturbances on those electrolytes include sodium, potassium, calcium, magnesium, phosphate, and chloride. As far as the symptoms are concerned, there can be a wide range, wide spectrum of clinical presentation. But the whole thing is, I would like to stress on one fact, that whether it is a nutritionist, whether it is a dietitian or is a clinician, he or she should always have a high index of suspicion that this patient is likely to suffer from dyselectrolytemia, and I need to be aware of it. I need something to monitor it, and I need to prevent such dyselectrolytemias, especially in sick patients. Just a recap, what we have been learning for years and years, how these electrolytes are distributed in our body. If you look into it, basically they are classified into two compartments, the intracellular compartment and the extracellular. And if you look into the cations and anions which are present in the extracellular compartment, you'll find that the predominant cation is the sodium and the predominant anion is the chloride. And if you look into the intracellular compartment, potassium, magnesium, and phosphate, they are predominantly intracellular. So now what is the implication of this distribution? We need to understand. The implication is that when we are monitoring sodium, we are monitoring the extracellular cation. But when we are monitoring the levels of potassium, when we are monitoring the levels of magnesium, when we are monitoring the levels of phosphate, we are just monitoring a very small percentage of extracellular present of these electrolytes. And there may be huge deficit, total body deficit of these electrolytes in a particular patient, which we need to correct and understand. So this is the whole importance of understanding the electrolyte distribution in intracellular and extracellular compartment. And we never study the electrolytes in isolation. Basically, it is the fluid and electrolyte distribution. And one of the most important fluid in our body is water. We all know that 70% of the body weight is nothing but water. And these electrolytes, they help in the distribution of water, the redistribution of fluid and electrolytes in the various compartments of the body. Now, if you look into the clinical manifestations, they are equally important. You just take phosphate and you look at the cardiovascular manifestations. It can present with congestive cardiac failure, severe hypophosphatemia, arrhythmias, hypotension, Patients can present with cardiomyopathy if they have got persistent hypophosphatemia for months. Renal system, skeletal system, they can involve the central nervous system, endocrine system, and the hematology. So as in totality, what I would like to stress is that any electrolyte has got the capability to involve each and every organ of the body. Potassium, extremely important for the cardiovascular system. Similarly, for respiration, patients are hypoventilation, patients have got poor ventilatory capacity, and when they come to us and when we monitor the electrolytes, patients with neuromuscular disorders, patients with myasthenia gravis, patients with GB syndrome, now when they come to us and we do an electrolyte assessment of those patients and we find that the potassium is 2.5. So what is that potassium doing? It is contributing to the muscular weakness. Now we are adding to the disease. We are adding to the disease by not monitoring potassium. Hypoventilation. Similarly, weakness, fatigue, muscle twitches, diarrhea, nausea, vomiting, lot of acid-based disturbances, they can all be caused by dyselectrolytemias. Now look at the magnesium, similarly sodium. Now what I need to make you understand again is that we should not deal with the single electrolytes. All electrolytes are linked with each other. If there is a sodium imbalance, it will lead to potassium imbalance. If there is a potassium imbalance, it may be because of magnesium imbalance. If there is a magnesium which is going up and down in a patient, it may be because of the calcium. So what we need to understand is that one electrolyte is never present as a dyselectrolytemia in any patient. It may be a combination of dyselectrolytemia which may be going on in any patient. Now, so what we need to understand? So what we need to understand is that what are the risk factors for electrolyte imbalance? Especially there is a special group of patients who are more prone for dyselectrolytemias. They involve patients like chronic kidney disease, patients presenting with prolonged periods of vomiting and diarrhea, poor nutrition. We are never in a habit of taking the nutritional history. Even my residents in ICU, we always ask them that what is the nutritional history of the patient, and we realize that the patient has been sick for several weeks, lying at home, not taking proper nutrition. And then we do the battery of tests and we do the battery of electrolytes, we realize that he has got all sorts of these electrolytes. Patients with dehydration, patients with acid-based disturbances, patients with congestive cardiac failure, volume overload, increase in the total body water will ultimately lead to dyselectrolytemias, especially hyponatremia and then associated electrolytes. Patients on some drugs which can interfere with the movement of the electrolytes, which can interfere with the distribution of the electrolytes in the various compartments of the body. We need to go into that history of that patient, especially those patients who are elderly and they are on diuretics. We see a lot of patients who are hypertensive and on diuretics, elderlies, they always land up in the hospital with severe hyponatremia. They land up with altered sensorium and altered consciousness. And when we look at the sodium, we found it is 115, 120. What we do is like what I feel like, I may be wrong, but what I feel in the regular practice is that I do not ask for any sodium restriction for elderlies. Never ask for sodium restriction in elderlies. Their intake is already low. They are 70s and 75-year-old individuals, and you ask them to restrict the sodium intake. Their intake is already low, and when then they are on diuretics, they have got multiple comorbidities. And once their sodium starts dropping, they land up in hospitals just with encephalopathy. Age itself is a big risk factor for electrolyte imbalance. As we go and advance in age, the reservoirs, the fluid compartments, they all start shrinking. The body capacity to handle electrolytes and fluids, that also starts shrinking. So what happens is that these individuals become more prone for electrolyte disturbances. So we should understand what are the risk factors. And if you look into the recommended dietary allowance, which I have got of 2019, it is not necessary to mug up these values. These values should be always available in the wards. And whenever you are prescribing nutrition to any patient, it is recommended that please go through this recommended dietary allowance. Especially you look at the calcium, the phosphorus, the magnesium, how much milligrams is needed, convert them into milliequivalents if you are giving through intravenous route, or if you are giving some standard formula feeds. See that how much it is needed if the patient is on antral nutrition, or whether you are prescribing the parenteral nutrition. Watchful for sodium and potassium. Normal requirement, a daily requirement for sodium is around 1 to 2 milliequivalents per kg, and potassium 1 milliequivalent per kg. These values are not to be marked up, but everybody should know that this is the minimum requirement of the patients, which may vary if the patient has got some renal disorder, decreased urine output, AKI or something. These values can be modified depending upon the monitoring. So I'll now touch some of the common dyselectrolytemias, and first I will deal with dysnatremia. Now, what is dysnatremia? Now, over a period of last decade, what has happened that people have realized that we do not talk about hyponatremia or hypernatremia. Now we talk about dysnatremia. The reason being, dysnatremia, if you say sodium more than 145 and sodium less than 135, hyponatremia and hypernatremia. But yes, now what the clinicians and the researchers are saying is that even the sodium changes within the normal value can change the outcome of the patient. That means if the patient has got an admitting, if the patient is admitted with a sodium of 140, and if you encounter in the next 2 days the sodium moves to 135, be cautious. He has brought about a change of 5 milliequivalents in 2 days. If you are not careful at this point of time, then in the next 2 days, the patient may have a sodium of 130, and then we start treating hyponatremia. So this is what the concept of dysnatremia has evolved over the last 10 to 15 years. Now, why I talk about dysnatremia, this is one of the most common electrolyte disturbance in clinical medicine. The prevalence ranges somewhere from 25 to 45%, and it has been classified based on the time of onset. What is the threshold for diagnosis? Now you understand the threshold for diagnosis. Some people are not worried even with the potassium sodium of 130 because the patient is doing fine. So this is the threshold for diagnosis, and they are not labeling in the diagnosis hyponatremia. Like we write community-acquired pneumonia, sepsis, multi-organ failure, we should be in the habit of writing dysnatremia, hypokalemia, hypomagnesemia, hypophosphatemia. And when we start writing this in the clinical diagnosis, then only we become eager to treat it. What is the population being assessed? That is equally important. Now, what I want to highlight is that even mild hyponatremia and hypernatremia have been found to be associated significantly with a higher mortality and a longer duration of hospitalization, especially in the vulnerable group. Now, how to classify hyponatremia? It is classified by two methods. One is the lab value, mild, moderate, and severe, 130 to 135, 125 to 129, and anything less than 125 is called severe hyponatremia. And then the another way of classifying is based on the duration, whether it is acute or chronic, less than 48 hours or more than 48 hours. Now, most of the patients who come to us, they are in chronic hyponatremia. They never land up within 48 hours. So immediately if you encounter hyponatremia, label them as chronic hyponatremia. Label them as with the value that whether it is mild, moderate, or severe hyponatremia. Now, the importance of classification is in the management. What type of management we are going to provide to these patients? What are the causes? The causes can be, now sodium and water. A very simple thing to remember is that sodium and water, they always move in opposite direction. Very easy to remember. So if the sodium is high, the water, total body water is less. If the sodium is low, the water, total body water content is high, except in certain situations, which is not commonly encountered. So most of the times, we need to remember that sodium and water, they move in opposite directions. So hyponatremia could be either because of increased volume of extracellular fluid or because of excessive water intake. These are some of the studies just to highlight and re-emphasize the fact that dysnatremias add to the mortality. And a very commentary which was given, published in Critical Care suggests, do sweat the small stuff. You should sweat. You should think. The clinician at the bedside should think that even the small changes in sodium can affect the overall outcome of the patient, especially in patients with comorbidities, patients who are presenting with acute illness. Patients have a lot of neuroendocrine and inflammatory responses to the trauma and stress. The medications, if you look at the prescriptions going on in critical illness, there are almost 20 prescriptions which are going on, and all of the salts, they have sodium. They have sodium in them. No antibiotic is without sodium. No salt is there without sodium. So if you start calculating the sodium content which is going to the patient, it is much, much, much beyond the need of the patient. And that is why these patients may manifest with dysnatremias. Now, there are a lot of studies from the West, but I encountered recently a study which has been published in June 2020. This is the study from Sher Kashmir Institute of Medical Sciences, Kashmir. And what they did is, over 3 years, they tried to look at the electrolyte imbalance, just the electrolyte imbalance for the patients who got admitted in the emergency. It had more than 12,000 patient episodes. And what they found was that sodium disturbances were the most common disturbances, and especially hyponatremia, followed by potassium, and the least electrolyte disturbances was with the calcium. So sodium is one of the most common dyselectrolytemia encountered in all group of hospitalized patients. Now, how to correct hyponatremia? There are a lot of formulas which are given in the textbooks, a lot of practices, but one formula which we find very useful at the bedside is the Adrog-Medeas formula. And it's a very simple formula. The change in serum sodium is equal to the infusate sodium, means the fluid which you are giving, what is the content of the sodium in that fluid, subtract the serum sodium, what is the existing serum sodium, divided by total body water plus 1. And plus 1 is because it is calculating the amount of sodium in 1 liter of fluid which you are giving. So you are adding 1 liter to the total body water, and you're increasing the total body water by 1 liter. So that is why this formula is change in serum sodium is equal to the infusate sodium minus serum sodium over total body water plus 1. Now, the importance of this formula we need to understand is that whenever you are correcting hyponatremia, you have to be cautious for that you should not overcorrect. It has to be very slow. Total correction should not be more than 6 to 8 milliculents in 24 hours. Rapid correction is never to be done. And this formula, what it does is that if you correct sodium based on this formula, you can change the fluid, sodium containing fluid, on every 3 to 4 hourly basis. So whenever you're monitoring hyponatremia, you're correcting hyponatremia, and you're using any of the fluids to correct sodium, you should monitor the serum sodium on a 2 to 4 hourly basis. And once it starts stabilizing, then the frequency of monitoring can be increased to 6 hourly or 12 hourly. And why we are worried? Osmotic demyelination syndrome. Never correct more than 6 to 8 milliculents per day. So that means it is not an easy task to correct hyponatremia. The patient needs special treatment, special monitoring. And at the same time, as I told you earlier, all electrolytes are linked with each other. They always do a crosstalk amongst each other. Always look, if you have encountered a sodium abnormality, look for sugars, look for malnutrition, for other malnutrition possibilities, look for potassium, look for phosphates, because they may be coexisting and they can contribute further to osmotic demyelination. Now, as far as the treatment, I told you, when you're using the Adrog-Medeas formula, you can use hypertonic saline, normal saline, or any sodium-containing fluids. But the crux is that you should know that it has to be a very slow correction, not more than 6 to 8 milliculents per day. So the key message for hyponatremia would be, if the patient is having some CNS manifestation, altered sensorium, seizures, convulsions, encephalopathy, and the sodium level is less than 110, you can treat it very fast by giving a bolus of 3% saline. But once the moment you reach a safe value, then the rate of correction has to be very slow, and then it should not be more than 6 to 8 milliculents per day. You have to assess the clinical profile of the patient in totality, and whenever you are treating sodium, the monitoring has to be very intense, very intense. It has to be not more than 4 hourly, not less than 4 hourly, because otherwise there are chances that you may overshoot the sodium correction and can land up in problem. As far as hypernatremia is concerned, it is relatively less as compared to hyponatremia. And it is most of the times, as I told you, sodium and water move in opposite direction. So if there is hypernatremia, there is a deficit of water. And most of the the patients where we encounter hypernatremia is the elderly group or the patients where there is some fluid restriction. So they have less fluids and the sodium goes up. How to calculate the water deficit? Again, a simple formula. 0.6, you multiply it by the body weight, and then you multiply by the serum sodium divided by 140 minus 1. And this is just to tell you an example of a 50 kg adult. You calculate what is the water deficit, you add the insensibles, and then you divide it on the 24-hour basis. Now, how to replace water deficit? If the patient can take orally, then it is oral water. If the patient is on enteral nutrition, then you have to give water through the Ryle's tube. And if the patient is on parenteral nutrition and cannot take enteral or cannot take orally, then you have to supplement free water from outside. And the free water from outside is nothing but 5% dextrose. No dextrose other than 5% dextrose provides free water. 5D, the moment it goes inside your blood, it gets converted and metabolized into free water. And that is the only way of correcting intravenous free water to the patient who is suffering from hypernatremia. Coming to phosphate. Now, I am very much fond of phosphate and phosphate imbalance. And because it can lead to a very significant syndrome, which can be a life-threatening syndrome, which is the refeeding syndrome. Refeeding syndrome is not just phosphate. Actually, it is a combination of electrolytes. But then the people, the clinicians, initially they realized that one of the most marked deficiency which presents in these patients is hypophosphatemia. How do we classify hypophosphatemia? Again, based on the levels, mild, moderate, and severe. No need to mug up. Just we should know what are the normal levels. Anything more than 2.5 to 5 milligrams per deciliter is normal. Those patients who have got a tendency to go towards hypophosphatemia, we always try to keep them in the higher side unless and until we encounter some renal issues. We try to keep the phosphates on the higher side for patients who are weaning from the ventilator, the patients who are on TPs, the patients who have got neuromuscular weakness. So we try to keep the phosphates on the high normal side. And that is why whenever we are weaning the patients, whenever we are providing some respiratory support, we monitor potassium on a 24-hour basis. And sometimes even when we are correcting moderate or severe hypophosphatemia, we have to monitor phosphate levels on a 12-hourly basis. And you know it, as I had told in my previous slide, that majority of the phosphate is intracellular. So what we are monitoring is not the true phosphate levels. And the moment the fluid distribution and the phosphate redistribution starts, you may again encounter hypophosphatemia. So whenever you're dealing hypophosphatemia, my recommendation would be that we have to increase the intensity of monitoring. Let it be 24 hours until unless you have achieved a stable level for at least 3 to 4 days. Now, these are some of the risk factors. I will not go into the details of risk factors for hypophosphatemia, but it can be related to decreased intestinal absorption, internal redistribution due to a number of causes, and increased renal excretion. Now, there are some special causes particularly restricted to critically ill population, which includes sepsis, trauma, fluid therapies, refeeding, and acid-base disorders. And especially also on patients who are on renal replacement therapy, they may manifest with hypophosphatemia. Now, monitoring phosphates. Now, this is very interesting. I went through one of the studies published in 2012, and what I found, there is no consensus that how the phosphate should be monitored in hospitalized patients. Some are doing daily, some are doing only on admission, some are doing on a weekly basis. And if the recommendations are that first, the electrolyte profile should be done at admission, then depending upon the necessity for the treatment, we can go on the intensity of monitoring. And especially if those patients who are on renal replacement therapy and the patients, those who are on total parenteral nutrition, daily monitoring of phosphate is needed. Daily monitoring of phosphate is needed. And these are a huge list of refeeding syndrome, but I would like to stress only on one. Overzealous treatment of patients who have been underfed for more than 5 days leads to refeeding syndrome. Treat your patient, feed your patient, but again, be aware of the electrolyte, dyselectrolytemia, which is likely to occur the moment you start nutrition for your patients, especially in the elderly populations. And this is the sequence of refeeding syndrome. There is malnutrition, followed by nutrition, and this lands up with refeeding syndrome. So again, the treatment strategy would be supplement electrolytes, correct phosphates, keep a watch on magnesium and potassium. Glucose monitoring is equally important. Insulin is important to correct hyperglycemia, correct the fluid balance, and one of the most important treatment aspect for hypophosphatemia or refeeding syndrome is thiamine supplementation. The moment there is increased insulin secretion and the metabolism of the glucose increases, the thiamine utilization increases and they land up with thiamine deficiency. So you have to give all patients with refeeding syndrome need thiamine at least 300 milligrams initially, followed by 100 milligrams daily for at least 7 to 10 days. What we practice is all patients who come to us with history of poor intake for more than 5 days, we give a routine thiamine supplementation to all patients. And this is the phosphate which is available to us. Potphos, 1 ml gives 3 millimoles of phosphate. And we have got some oral phosphate also available with us in the form of Adphos sachets. And one sachet gives 16 millimoles of phosphate. So whenever our patient lands up with moderate to severe hypophosphatemia, if the patient, we are not worried much about the neuromuscular components or the disturbances that we may like to go for enteral, then we go for Adphos. But if we need to correct intravenous phosphatemia, then we go for potassium phosphate correction. Dyskalemia, yes, it is less common, and I'll not go into much of the details, but yes, we should know the functions of potassium. We should know that it is one of the most important intracellular cation. Only 2% is extracellular, and we should know the daily potassium need of any individual who is hospitalized. How to give it, whether through the enteral route or through the parenteral. It plays a role in the osmotic integrity of the cells, maintains an acid-base balance, contributes to a lot of reactions that are taking place in the different cells, and plays a role, extremely important role in excitability of the skeletal, cardiac, and the smooth muscle. Hypokalemia is more common than hyperkalemia, but whenever we encounter hypokalemia, we should always monitor the magnesium levels, because the exact mechanism is still not known, but it is believed that magnesium helps in reabsorption of potassium and helps in movement of potassium. So if you are not able to correct hypokalemia by all whatever means you are taking, and still the patient is presenting with hypokalemia, always monitor magnesium or give empirical magnesium to that patient. There are several mechanisms for hypokalemia in hospitalized patients, but one of the most common reason for hypokalemia is decreased intake. And if you go into for oral correction, you have got syrups like pot chlor and pot citrate. But as far as those patients who have got arrhythmias or manifestations of severe hypokalemia, then the recommendation is that we have to go for intravenous potassium correction. Hyperkalemia, yes, restrict the potassium. Look at whatever sources the patient is getting, maybe a lot of antibiotics, drugs. So you need to go into the history, go into the antibiotic history, look at the prescriptions, look at the nutrition which the patient is getting. Maybe he's getting too much of potassium. If he does not have any renal issues, the creatinine is normal, the patient urine output is fine, then why should he land up with hyperkalemia? So immediately review your nutrition and the drug history for the patient. As far as other electrolytes are concerned, magnesium, yes, it is essential. It plays a crucial role in biochemical and physiological processes in the human body. But the most important aspect about magnesium is that it is also common deficiency in hospitalized patients, but it's most of the times it coexists with other electrolyte abnormalities. Similarly, calcium, it is less encountered, only in a special group of disease population, maybe some endocrine disorders or chronic kidney disease, or maybe some other disorders where the calcium abnormalities are encountered. But yes, whenever you suspect hypocalcemia or hypercalcemia, you need to do an ECG, you need to do a total calcium, you do need to do the endocrine workup, and you need to look at the ionic calcium, and then you need to correct the hypocalcemia or hypercalcemia. So I would like to conclude that electrolyte panel should be a part of a routine nutrition assessment of any hospitalized patient. All electrolytes are closely related with each other. We should be in the habit of reviewing the drug history, the drug intake of the patient, what prescriptions are going on, and also have a review of the nutritional history, the acute nutrition and the chronic nutrition, what have been the nutritional history for your patient. And if any level of an electrolyte is found to be abnormal, the correction should start on an immediate basis. It depends upon the nutrition of the dietitian and the combination of the multidisciplinary approach of the clinician, what should be the method of correction, but at least it should be discussed that this electrolytemia needs immediate treatment. And as far as the monitoring is concerned, it depends on two conditions. One is the severity of the dyselectrolytemia and the rate at which you want to correct that abnormality. Thank you very much. Thank you.